right, I think I'll go ahead and start. Thanks for joining. My name is Amber Warren. I'm the DIO and Program Director at Cornerstone Care Teaching Health Center Family Medicine Residency Program. We're located in Mount Morris, Pennsylvania, which is just north of Morgantown. Our residents rotate at Mon Health Medical Center. And today I'm going to go over the treatment of restless leg syndrome and periodic limb movement disorder. This is a clinical practice guideline that came out last year from the American Academy of Sleep Medicine. And the previous update was from way back in 2012. So there's a lot of new information in here and several practice changing recommendations. So here's our learning objectives. We're going to go over the treatment, understand methodology, and look at some practice changing points. I need to mention that I have no conflicts of interest or disclosures. So first, we are going to review the clinical overview. So most of you all are aware of restless leg syndrome and how it's diagnosed, but this is the urge to move your legs during rest. It's worse at night. Sometimes it actually can affect the arms. It's typically relieved by movement and is often associated with dysesthesia, so unpleasant or painful sensations like burning, tingling, electric shocks. And it's a major cause of insomnia and impaired quality of life. So clinically significant RLS happens at least twice per week and causes a moderate amount of stress. So this international RLS severity scale is something you can use to decide how severe a patient's symptoms are. It's 10 questions rated from 0 to 4, and it's what they use as a requirement for FDA approval of medications. So RLS occurs in 2 to 3% of adults. It's higher prevalence in females in pregnancy, also with end-stage renal disease and iron deficiency, often comorbid with mood, anxiety, and pain disorders. And SSRIs can worsen RLS. So serotonergic meds can increase serotonin activity, which interferes with dopaminergic pathways, and that's how that works. Often you exhibit periodic limb movements during sleep. So there's PLMS, which is just the limb movements commonly found in RLS. And then there's PLMD, which is the periodic limb movement disorder, which I have next here. And this is the actual disorder. Now, the title talks about this update, including PLMD, but actually like 95% of this update just looks at RLS. But this is repetitive limb movements during sleep. Typically, to diagnose it, it requires frequent events greater than 15 per hour. It's detected on sleep study. Usually it's 0.5 to 1 second recurrent flexion movements of your lower extremities, and it causes significant sleep disturbance, not otherwise explained, and you have an absence of other sleep disorders. It's the only recommendation in this update is that they recommend against the use of triazolam and valproic acid. So the pathophysiology of RLS isn't well understood, although they talk a lot about this brain iron deficiency. Also, genetics play a high role. So those associated with systemic iron deficiency, so pregnancy, end-stage renal disease, like I mentioned, have an increased risk of RLS. So the studies that were looked at found they used MRI, transcranial Doppler, and CSF analysis, and it demonstrated reduced brain iron indices in people with RLS. So I thought this was very interesting. You know, we're not doing these type of things to figure out what your brain iron is. And I read that in patients with a normal serum iron level, they might have a reduced brain iron level. So you still might want to consider treating. So I thought this was very interesting. And RLS is strongly inheritable. About half of people with RLS have a first-degree relative with the disorder. All right, so the American Academy of Sleep Medicine commissioned a task force of experts to develop recommendations and assign strengths based on systemic review of literature and assessment of evidence using the GRADE framework. So the task force provided a summary of the relevant literature and certainty of evidence. They balanced the benefits and harms and patient values. And in the end, the AASM Board of Directors approved the final recommendations. So they looked at articles through September of 23, and the level of recommendations were classified as either strong or conditional. They considered them strong for or strong against, or conditional for and conditional against. Now, if you look back at the 2012 CPG on RLS, they had different levels of recommendations. So they had standard treatment, guideline level recommendation, and optional level recommendation. So the standard treatment was dopamine agonists. And this study was not designed to look at augmentation, which we'll talk about in a minute. Guideline level recommendation include levodopa, carbidopa, opioids, gabapentin, and carbil. So this gabapentin and carbil at the time was new, and it warranted a lower recommendation. And I'm mentioning that specifically because we'll talk about that in a minute. And then optional level recommendation was gabapentin and pregabalin and some others. Again, they had a side effects mainly was the reason why they were lower on the list. So augmentation that I mentioned earlier, this is an iatrogenic worsening of RLS symptoms with dopamine agonists. So this is patients who start on Requip, for example, and over time, they do well and it works. And that's why it was, recommended at the top formerly. And over time, their symptoms get worse. And it's being on the medicine that makes the symptoms worse over time. So we increase the dose and we increase the dose. And it's a vicious cycle. So this time they put a special emphasis on augmentation as a critical outcome. So the key outcomes that were assessed in this study, they looked at the disease severity, and they used the IRLS scale for this. They looked at sleep quality, quality of life, adverse effects, and then also augmentation. So before reviewing the recommendations, which we'll go into in detail, they came out with good practice statements based on expert consensus. And it's recommended that you check ferritin and transferrin saturation in all RLS patients, address exacerbating factors, so caffeine, alcohol, serotonergic meds, antihistaminergic meds, antidopaminergic meds, and look for OSA symptoms. And then consider your pregnancy-specific safety profiles. Now, with checking iron, they mentioned that it should be ideally measured in the morning, avoiding all iron-containing supplements and foods at least 24 hours prior to blood draw. Now, I don't know about you, but I usually just ask my patients if they can get some blood work and I'll take them to the lab. So I am certainly not asking them to abstain from iron-containing meds and foods for 24 hours. I can barely get them to come in 8 to 10 hours fasting. So the iron replacement thresholds that they recommend is also very interesting. So the ferritin recommendation is a cutoff of less than 75 or a transferrin saturation less than 20%. They recommend oral or IV iron. So if you look at the asterisks a little lower, you can see the LabCorp normals are 15 to 150 for females and 30 to 400 for males. So typically when I got labs on patients, if their ferritin came back at 35, I was not putting them on iron. However, these ranges are different for the general population if you have RLS, so they have a higher cutoff. And then 75 to 100 is IV iron only. So they recommend IV iron because there's poor GI absorption at that point. And then a note for children, their cutoff was 50, less than 50, and you could start oral or IV iron. However, you have to be careful with the constipation issue that comes with iron supplementation in children. Now, I will note that IV iron is not reimbursed by payers for RLS. So the only time I can get patients to get IV iron is if they have anemia and they're not responding to oral medication. So they have IV iron as a treatment option. However, we as family practice won't be able to get that for our patients. So this is the chart. This is a very busy slide, but I wanted to include this because this is the chart that they published in the guideline that you can see here what they looked at: severity, sleep quality, quality of life, the augmentation of RLS symptoms has its own column, and then adverse effects leading to study withdrawal here. And gabapentin and carbil, pregabalin, and IV ferric carboxymaltose, those are the top four I have in the red box. Those are the ones with the strong 4 strength of recommendation. And we'll talk about each of these in detail here. So here they are, the top 4, gabapentin and carbil, and is listed there at the top. And I don't know if anyone has prescribed this before, but it's a prodrug to gabapentin. It's a longer, like an extended release. You take it once a day. And it's not covered by insurance very well. So actually, after I was given this topic, I had read the article a few times, and then my one patient, who's in his late 50s to early 60s, has the worst case of restless leg syndrome that I've ever seen. And he has even come to me as an acute patient one morning because he slept for 20 minutes because his RLS kept him up all night. So we have tried multiple medications for him, and nothing has worked for him so far. And I've even tried Valium on a whim, and it doesn't work. So I met with him a couple months ago, and I told him about this new gabapentin and carbil, and I told him I wanted him to start it, and he was agreeable. And I told him I'd have to wean his Requip, which we'll talk about here in a minute. It's very difficult to do. And he's on 4 milligrams of Requip at night. So I sent the prior auth for gabapentin and carbil myself, and it got approved, but only he had to pay $90 per month, which he was not willing to do. So he's not going to start the medicine, but we're going to try gabapentin instead. But just I would love to hear if anyone has prescribed this and their patients have been on it. You can put it in the chat if you'd like. But these are the top 4. Your IV ferric carboxymaltose is a slow release, higher dose formulation. So since I don't prescribe IV iron, I wanted to list these options here so we can get a little familiar. So the top 4 there, the carboxymaltose, ferumoxytol, and low molecular weight iron dextran are all slow release, high dose iron, and they are recommended. The iron sucrose is typically used in end-stage renal disease patients. And the oral iron we're very familiar with. You have your ferrous sulfate, your slow release, which is has lower GI side effects but reduced absorption, and then your higher dose oral iron, which usually you're limited by GI side effects there. So why dopamine agonists were downgraded? So it's the augmentation. So the worsening of symptoms over years to months, and it's difficult to wean these patients. So tapering and discontinuation of dopamine agonists can be very challenging due to the rebound that you may have. And so they don't mention how to wean your patients off of your dopaminergic meds. I am just on my patient that I mentioned earlier, I'm going to decrease him from 4 to 3 milligrams only because I don't think he will cut the pill in half, and will be on 3 milligrams for several months and see how he does while starting gabapentin. And they do mention that even after you stop the Requip or the dopaminergic meds, that they could have persistent symptoms, and that the gabapentin and carbil could be less effective in those patients, which makes our lives more difficult. So the next group was the conditional 4 treatment options, and this is oral iron, your IV dextran and ferromoxetol, dipyridamole, which is our antiplatelet, opioids for refractory cases, and perineal nerve stimulation. And I have a couple of slides on these in detail. So the opioids, this is for severe RLS because you have risks such as overdose and dependence. So it's reserved for select patients, but it did make the list. And then I put a picture here of the perineal nerve stimulation. It's like a strap that goes below the knee, and it may have a small benefit. You could consider it in refractory cases, but I thought that was interesting to try. And then next, we have our conditional against group. So this is where your dopaminergic meds come in. You see the top 4 have an asterisk, and and they state here that they may be used to treat RLS in patients who have a higher value on reduction of symptoms with short-term use and a lower value on adverse effects with long-term use. So if you had, for instance, a patient who has symptoms maybe 2 or 3 times a week, you could give it as needed for those patients, or maybe for those who have a long plane ride and they really want some symptom relief, you could give it in that situation. But you would really have to just talk to your patients about this augmentation effect before you start your patients on dopaminergic meds. And you can see the rest here, bupropions in here, carbamazepine, Klonopin, valerian, valproic acid. And then there was only one in the strong against category, and that was cabergoline. So they list some special populations, which is your end-stage renal disease, and they had a conditional 4 level of recommendation with gabapentin, IV iron sucrose, and vitamin C, and conditional against with levodopa and transdermal ribitogatine. So I have just one other slide on the PLMD, and they mentioned that this is a controversial diagnosis. Literature is devoid of treatment studies within the past 2 decades. So there's no recommended pharmacologic therapy stated in this update. They do advise against triazolam and valproic acid. So I'm not sure we're diagnosing people with PLMD. I assume it's more you're seeing PLMS with restless leg syndrome. And then pediatrics, very little published literature on this. Conditional recommendation for iron. However, you need to consider the side effects of constipation because that could potentially be worse than the RLS itself. So the potential sources and bias of limitations here, I thought about this for a while, and there's many conditional recommendations based on small RCTs that the task force looked at, and or observational studies. Some of the trial durations were short, so it may underestimate long-term harms. There was industry sponsorship in some pharmacologic trials. So a task force member served on the steering committee for a pharmaceutical company investigating the IV ferric carboxymaltose. So this was one of the ones in the top 4 listed as a strong 4 recommendation. So he served on several RLS boards and consulted for several companies and received grants for research. So it makes me a little leery about giving that IV. Well, we wouldn't give the IV anyways, but it's interesting that it was listed in the top 4 there. And then limited pediatric and PLMD specific evidence. And then the medication dosages were not discussed. And also, I don't have on here, but the weaning of how to wean the requip would be nice as well. So practice changing points. Just in summary here, your gabapentinoids are first line therapy now. Dopamine agonists, no longer standard treatment. Caution with tapering on those. Routine iron assessment is essential. And you should check their iron labs before and then during throughout their therapy. IV iron is recommended, but we are unable to get it. consider other causes that could be worsening the symptoms. That should probably be listed up top. So that would be those with asking about caffeine and alcohol, serotonergic meds, obstructive sleep apnea symptoms. And then I listed acupuncture and OMT here because I know we have some acupuncturists that join these lectures. So if you all have ever treated RLS with acupuncture, I'd be very interested to hear if it worked. And I am a DO, so I had to put a nod out to OMT for this. I have never treated restless leg syndrome with OMT. However, I did a search because I was interested if there's any good techniques out there. And I found a couple articles that were interesting. The ACOFP put out an article about some counter strain and trigger points to your lower extremity muscles, which help with symptoms. And then an interesting RCT of 60 patients. And there were osteopaths who had a private practice in Germany and Switzerland, and they found some techniques that worked. So I have those references at the end for those interested in that, if there's any DOs out there. But in this guideline update, the task force found insufficient evidence for a long list of different items here, including acupuncture. They didn't even mention osteopathy, but they mentioned Botox, CBT, tramadol, vitamin D, yoga, all of that showed insufficient and inconclusive evidence. So conclusions here, guidelines emphasize long-term safety and augmentation risk. That was the big one here, is the augmentation was the big thing they looked at, shifting away from dopamine-based therapy and support individualized and patient-centered care. And these are this top is the actual clinical practice guideline in a PDF link. And these are the two osteopathic references there. Any questions? I have a case with a couple questions involving the case.